Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining us. Today's guest is Dr. Matthew Welch, vitreoretinal surgeon specializing in complex retinal diseases, pediatric and adult retinal care, and ocular oncology, including the diagnosis and treatment of choroidal melanoma. Dr. Welch, thank you and welcome to the show.
Well, I'm so glad to be here.
All right, that was a lot, and I glossed over a ton because you're an absolute rock star. You've spent a lot of time in school and a lot of training, that's for sure. Can you give us a little background on yourself?
Yeah, it's true. I on a daily basis, I think to myself, gosh, I don't know that I would be able to survive that over again. But here I am, and I'm very glad that I did it all. I'm a guy from born and raised in Minneapolis, Minnesota. Then actually
Apple Valley.
Apple Valley. That's true. Yeah,
That's
go
awesome.
Eagles. And came down to the U of A for college. Went to Chicago for my medical training through ophthalmology. Came out to Arizona for fellowship training, so some postgraduate work. Went back to Chicago and then kind of like boomerang back to the Phoenix area in my group in 2015, and have been doing the work in my practice at Phoenix Children's, at a couple of the different hospital facilities throughout Arizona. Service central Arizona through Phoenix, and then I spend some time up in Prescott on a weekly basis too.
Okay, well said. You glossed over a lot. Going to medical school, going to surgery, going for surgical residency, going for ophthalmology residency, going for fellowships in your specialties is a ton of time and commitment and effort. Do you think that's changing moving forward, by the way? Do you think that there's going to be a lot of more of people going down those longer routes?
Medicine is definitely in a stressor right now, right? I mean, the costs of medical school are escalating, and then with the dynamic of the payer system and the Medicare fee schedule and the time bomb potentially going off as far as funding, the challenges are very real. When you look at it, primary care is really struggling and a shortage of physicians. But to your point, surgical specialty care is kind of more appealing, I think, these days to students in medical school, just because when you look at sustainable outcomes in a career, primary care is kind of in the crosshairs and is dangerous as you start to look at the proliferation of non-physicians like nurse practitioners and physician assistants, taking care of those kind of things. Surgical specialty care is a very safe zone. So I do think actually the numbers bear that a lot of students are going that direction. And it is a haul. I mean, to get to where I was, it was 4 years of college, 4 years of medical school, 4 years of ophthalmic training with a year of internship, combined in there, 2 years of retinal training, and then kind of a year apprenticeship on the ocular oncology thing. So the numbers add up and the time gets away from you pretty quick.
For sure. Well, kudos for accomplishing all that. That's all the hard path, and I hope it's paying off for you.
Yeah, I mean, on a daily basis, right? I have no doubt that I'm doing the right thing. However, like if you were to say, hey, you want to do that 14 years over again, where I'm at right now, I might take a pass.
Right. But we mentioned it before we started. I mean, the impact you're having day to day, you're helping people all the time, all over the place with stuff that most people couldn't deal with. So that's incredibly powerful.
Yeah, I mean, the reality of it is that a career as a physician is still, quite a noble profession, and as long as you stay grounded, you will realize that on a moment to moment basis. I certainly do.
Excellent. So, what drew you to ophthalmology?
My route to ophthalmology was by mistake, So I was a kid. I was just telling this to a patient yesterday. I was the kid that when I was 6 years old declared that I wanted to be a doctor, and like that version of doctor changed a little bit, but it never changed from a non-doctor. And when I arrived at medical school, my bachelor's degree is in exercise physiology. And so for me, the cardiopulmonary system was it. And I thought for sure heart transplant was the be all end all. And I got plugged in with the heart transplant unit at Loyola, where I went to medical school. And it didn't take me a week to realize that just didn't jive with my long-term plans for life. And so then, having been a college athlete, I tried to force myself to be an orthopedic surgeon, realized that was not going to be my jam. And after that, I kind of just floated through school. It was second year of medical school, and I thought, maybe I should have just got my PhD in exercise physiology. But you're kind of, down the rabbit hole, and you got to keep going. And actually, the only reason I did an ophthalmology rotation as a third year medical student is because Loyola University has the largest burn trauma unit in the Chicago area, and I had been working in the burn unit, and those were like 3 a.m. to 9 p.m. shifts consecutively. And I hadn't had a regular meal during waking hours in some time. And my best friends at the time said, "Hey, I did the ophthalmology rotation. They stopped for lunch." And I said, "Well, that sounds good." So I did it purely just because they stopped for lunch. And on the third day, I saw a retina surgery, and I knew that's what I wanted to do. And literally, so the third day of that rotation, I declared myself a retina surgeon, and here I am.
Okay, wow, that's awesome. You reminded me a little bit of my wife. In medical school, she thought she wanted to do clinical work and stuff, and then she had her fill of talking with people regularly, and decided she really liked the procedural stuff more. And she actually mastered in surgery, did a few years of that before she switched to anesthesia, where she can just put people to sleep and they can't talk anymore.
Yeah, they always win the conversation.
Yep. Okay, so let's and then how do you go deeper into vitreoretinal surgery?
Well, I mean, that was, that was what caught me, was retina surgeon. I remember I came up to that again. I was on a general ophthalmology rotation. I said to the resident, the trainee that I was assigned to, I said, "Well, I want to be a retina surgeon." He says, "Oh, that's a bad idea." I said, "Why is that?" And he says, "They've got the worst hours of the ophthalmologist. You want to just do cataract surgery? It's nice and calm, and they have to deal with ugly stuff." And I said, "No, no, no. I want to deal with the ugly stuff." So I was dead set on that. I mean, when I interviewed for my general ophthalmology, I told everyone, "Listen, I'm just doing this because I want to do retina hardcore." And so
It's
I was
super delicate stuff, right?
very
I mean, it's
delicate.
amongst the most delicate you could do. So is it technically very limited to the people who have that skill set?
Yeah, I mean, training is a strange thing. The application process. You look at, like, say, like the NFL, and they've got the combine, and they got you running and benching and catching balls, and they got
Right.
pro day and all this and that. And for surgeons, like, to a large extent, it's just kind of like, okay, so you're a nerd, great, you did some good tests, like some people wrote some good letters of recommendation for you, but there's really not a surgeon combine, right? Where let's see
Right.
how those hands are, how delicate they are. I mean, I did go on interviews eventually for fellowship where people wanted me to stack pills with toothpicks.
Really?
But, oh yeah,
Ah.
like, and they wanted to see what you did. But largely, like, it's either kind of self-declared, and then you kind of find out what you are. But without a
Right.
doubt, I mean, it's delicate. And as I was saying before we came on, I just came from the children's hospital, working on an 11-month-old with a tiny little eye. So, there's tiny little instruments and tiny little organs and not a lot of space to move. So,
No.
our margin for error is very small.
Okay. So let's dive right into that then. How much of your work is pediatric?
I think, like, in my practice, I'd say that probably maybe 10 to 15%. It's still a minority.
Okay. Okay. And are those developmental, or are they trauma type of?
It's probably a 50-50 split between that.
Okay.
Effectively, if you're seeing me and you're a child, either something bad happened to you, or you were kind of born with some deficits, and we're trying to correct those.
Okay. And then of the adults, most of it is the older population.
Yeah, I'd say the majority of our patients are kind of like the 60 plus, because you're dealing with a lot of macular degeneration, and then the retina as an organ tends to wear out with time, and so that's where things like floaters and retinal detachment and even choroidal melanoma tends to happen in an older population. So we see people of all ages, and in the 20s to 40s, it's probably mostly diabetes and complications of diabetes that punches your ticket to come see us. But it's my practice specifically is a widespread. I mean, the youngest person I've ever operated on was born 22 weeks premature, and the oldest person I operated on was 102 years old, and he told me he had things to do.
Wow, that's quite the span. You mentioned your group. Let's talk a little bit about your group. They're big, and they do a lot of different stuff.
Yeah, so my practice, Associate Retina Consultants, is the biggest, oldest, physician-owned retina practice in the state of Arizona. Actually, just I want to say a year or two ago, we had our 50th year,
Nice.
anniversary,
That's a big
and
deal.
yeah, it's a big group. We have 7 offices in the Phoenix metro area, and then we service 7 locations outside. And so basically, if you draw a line at Casa Grande, everything north to the Utah border, we provide retinal support for. And myself and a couple other of the surgeons in the group provide all of the coverage for Phoenix Children's, which basically provides all of the pediatric retina care, for the state. And so, we're a big, comprehensive group, and because of the nature of Phoenix medicine and not really being built with an academic center, we tend to provide all of the retinal coverage that a traditional academic department might provide in a city like Chicago.
Okay. Okay. Interesting. And what got you, is it just natural that a lot of your cases are going to be uh, oncology based?
I mean, so oncology is probably also like a 10 to 15%, slice
Okay.
of the pie for me, just because, the nature of ocular oncology is, it's not happening all over the place. When you look at choroidal melanoma, which is the most common tumor that you might see in an adult, there are only about 6 cases per 1 million people in the population in North America. So, that being said, there's probably less than 30 ocular oncologists in the whole United States, and so in a given year, I'm going to treat people with tumors in the eye from multiple states. I think maybe 3 years ago, I treated people from 11 states and 2 provinces, actually, from Canada. So I have people coming down, as far as away from Alaska and Saskatchewan, and then east or west Texas, I guess I would say, New Mexico, southern Utah.
Okay.
Just because of the limitations of practitioners that deal with those issues.
Sure. Sure. And I imagine that, like most Canadian healthcare, they're coming down also for speed.
That's their primary thing, right? I mean, because as they described to me, right, you might be first seen by your optometrist in Canada who says, oh, I think we've got a problem, and then you likely are referred to a general ophthalmologist who agrees that there's a problem, who then gets sent to probably a retina person who may or may not, in fact, deal with the tumor itself because of location. And so, as I understand it, for some of those people, it might be 6, 9 months before you actually have a definitive diagnosis, and then lead to treatment. Versus, for me, if I'm seeing someone, it's 6 to 8 weeks to getting it treated. So,
Okay.
pretty big difference.
And you said choroidal melanoma, that's behind the retina then, right?
It technically, yeah, it's a couple layers deeper.
Okay. And that's the most common. And that, like most of these, are the most dangerous, and time is a big factor.
Well, I mean, it's as I always say to my patients, it's a rare cancer, so we don't have a color or a ribbon or a march, but it's
Right.
still real cancer. If you go to the Dr. Google, the scary stat that's out there is roughly 50% of people with choroidal melanoma will succumb to metastatic disease, because when it spreads to your liver, which can be very challenging to treat.
Yeah.
I will say, though, locally here, I've partnered with a medical oncologist who really is cutting edge and has his finger on the clinical trial pathway. And so, personally, I've seen some really good success with unfortunate cases where people have metastatic disease and they're beating statistical odds. So, things are on the upturn
Excellent.
for sure.
Okay. Excellent. What do most people not understand about the retina, right? How it works, or how, I mean,
Just
how,
everything, right?
yeah. Okay.
I mean, thank good to the iPhone. That's the reason why people know there's a retina, right?
The retinal
Retina
screen.
scans or movies like The Minority Report or something like that, right? That's why people know there's a retina, right? But it's an underappreciated but heavily valued, right? Because it effectively is the tissue in your eye that lets you enjoy sight.
Right. Right. That's actually where I almost made that the focus of my graduate work. because in Utah you got to go fishing periodically to get the specimens.
There you go.
Go fly fishing regularly.
Yeah.
Um, and they have big eyes and they're easy to work on, etc. But okay, oh, speaking of retina, just in terms of how often do you see trauma, or it doesn't even have to be trauma, I guess, detaching, where the retina detaches and you have to go in and secure.
I mean, every week, right? I mean, like there probably everyone in my group is fixing multiple retinal detachments every week, and a lot of that just has to do with population dynamics, the number of people that live here in Phoenix relative to the number of retina surgeons, and then I guess reputation. But generally speaking, the quoted rate is about 1 in 10,000 of spontaneous retinal detachment. So when you live in a large place, that adds up. And then throw in, traumatic issues and things like that. So yeah, I mean, I think I fixed 5 yesterday.
Oh, wow. So that was part of my question is how much of it is trauma or versus just aging and use?
Yeah, I mean the majority is still non-traumatic, right?
Okay.
So I think probably maybe 20% would be true trauma. I guess in like kind of an asterisk different category, certainly having other intraocular surgeries. So if you have to have cataract surgery, you have to have glaucoma surgery, you have to have some other kind of surgery in your eye, that then poses an increased risk, for retinal detachment, just because now you've had surgery in the eye. So that would be kind of like a quasi, I've previously been traumatized through surgery. But the majority are they just happen. It has to do with the natural aging process of the eye, and or potential risk factors like being quite nearsighted.
Are you seeing an increase in the prevalence of any in particular?
I don't think so. I think the numbers, and that this is probably true nationwide, have bared out like pretty steady.
Okay. Okay. What are the causes for preventable vision loss today? The leading
I mean,
causes.
yeah, I mean the biggest thing, the biggest enemy with preventable vision loss would be diabetes. I mean, without a doubt, the rate and prevalence of type 2 diabetes, has increased quite rapidly, and it's kind of an underappreciated disease as far as what it can really do to you. I tell people on a daily basis, if I was an evil villain and designing a disease, diabetes would be my disease, because it's perfectly designed, because it will systematically just pick at the different parts of your body, your kidneys, your feet, sensation in your fingertips. And then the next thing you know, you can't see out of one eye because of bleeding or something of that nature. And I think a lot of people don't understand how severe the complications of diabetes can be. And certainly in my practice, I see this all the time, where people undervalue what can happen when you have vision loss, and that not all vision
Right.
loss is correctable, and that
Right.
that sometimes vision loss is permanent. And that is a hard pill to swallow when it happens. And without a doubt, people with diabetes have the ability to prevent and even reverse some of the changes that they have with blood sugar control, as they need to. So
Right.
without a doubt, if there was just one disease, diabetes would keep me employed.
Right. Right. Um, that is still increasing in prevalence. It doesn't, yeah, hopefully it'll slow down here. We can reverse more of it, but there's been a bit of a health renaissance, I think, in the US in the past 10 years.
I
Let's
mean, I
talk a
think
little.
people are starting to get it, because now you're starting to have generational type 2 diabetes where,
Right.
and that influences it, because I certainly see patients that are in their 20s, 30s that they themselves are now being diagnosed with type 2 diabetes,
All right.
but they saw mom or dad or whomever in the family lose a leg, lose vision out of an eye, and they're adamant, right, that they do not want to allow that to happen. So even though they're now afflicted with the condition, their trajectory is going to be very different, because they're much more motivated, because they've seen what can happen in the generation preceding them.
Right. For sure. For sure. On the surgical front, procedural, I guess, and maybe innovation stuff, have things changed drastically over the past decade or so?
I mean, I think without a question, ophthalmology in general, and then retina within ophthalmology is one of the most technologically advanced and advancing
Okay.
subspecialties of medicine. I mean, certainly when you look at just cataract surgery, the time it takes for cataract surgery, the fact that you can do it laser assisted, the number of options that they have for lenses has just skyrocketed, continues to go. In my field, the size of instrumentation keeps getting smaller and smaller. The efficiency of our surgeries, I mean, I might do a surgery in this day and age that takes me 15 minutes that maybe 10 years ago was even a 2-hour procedure. Or you might look at, retinal detachment. Maybe a decade ago might have been under general anesthesia, 2.5, 3-hour procedure. Now it's done under light sedation and might take as little as 30 minutes, and with improved visual outcomes. And so, the world of instrumentation and clinical trials is vast in our field. And so, what we're doing now kind of doesn't even resemble what you were doing maybe even 5 years ago, and
Wow.
that'll be true in another 5 years, and in 15. Everything, just the microscope technology, the instrumentation, the machines that we use, and all of it leads to better outcomes.
Okay. And how do you stay on top of it if it's changing so fast?
You read a lot. You read a lot. You pay attention, right? I mean, certainly with there's a whole field of podcasts in our field. Societies like the American Academy of Ophthalmology and the American Society of Retina Specialists, make sure that information, video, data is disseminated. So it's actually not so hard. You just got to put in the time and the work.
Okay. Well, I imagine a lot of it's technical, right? You have reps or somebody come in and show you the new toys.
Yeah, there's that, but I think actually the bulk of it is just peer-to-peer, interactions and discussions of techniques. And I mean, even in my group, I mean, one of the great joys that I have is that I've got a stable of surgeons that you can bounce ideas off and say, hey, how do you tackle this? Or I've got this interesting, or have you ever encountered this? Or what have you, and we've got a good age range and differences of opinions, a difference of training, difference of experience. Right. So, I still think it's a lot of just that, and we really benefit, and I do personally, with the local assets that I have, particularly in my group.
Right. Sounds like you guys are top notch. On the technical side, how is AI likely to impact eye care and disease diagnosis?
There are some applications for sure, and they continue to look at it. One of the things that is the most challenging, and even like the head of AI research at the National Eye Institute and the National Institutes of Health would tell you this, is that our field is full of nuance, and pattern recognition gets you so far, but nuance really gets you to the ultimate diagnosis and where the details matter. And that's one of the things that AI has had a hard time with, is with the nuance of it,
Sure.
And so I think it's going to be good as far as generalized screening tools, as ways to funnel patients to different providers and things like that. But I think ultimately, at the end of the day, you're going to need somebody sitting there and really scrutinizing the data and saying, yeah, okay, I see that there's this change, and on this image, I can see this finding, but I'm going to tell you what, in your circumstance, it does or doesn't matter. And, and that's really where the human component's going to continue to persist. I think AI will be helpful,
Sure.
but I'm not worried that it's coming for me yet.
No, it's there's fields or areas of medicine that have benefited greatly from it already, but there's I think you're right. The more I think about it, that's some pretty detailed, complicated, nuanced stuff.
Yeah, I mean, and I have these discussions. I was just at a meeting this weekend with some other physicians, and we were talking about AI and those kind of things, and ultimately too. I mean, one of the things that's going to always save the world of the physician is, at the end of the day, people want a person taking care of them, and human touch and contact. I mean, I see it all the time, right? Like a touch on the shoulder, a grab, handing a tissue over, during a difficult moment. At the end of the day, medicine is full of those kind of situations. You're finding out, in my field, your child's not going to see again. Your life is changing because you can't drive anymore, and that alters where you can live, what you can do.
Sure.
And so the human component in medicine, I think sometimes gets, shoved away to technology and computers, and we talk about these things. But at the end of the day, all we're doing as doctors is having people that are kind of otherwise strangers coming to us and asking for help and really putting their faith and their trust in us that we're going to do that. That's never going to be replicated by anything other than a person.
Right. And in your field, you have an incredible impact, probably quicker than most physicians, right? You can come in and make big life-changing impact pretty quickly and big impact on a lot of your patients. Is there a particular patient story that stayed with you through your career? I'm sure you have a ton of stories, but
Yeah, I mean, like that bag is probably as big as Santa Claus's, right? Because they add up really quick. I mean, one of the most I mean, it was intense for me when I was going through it, but it really kind of magnifies what we do is again, young type 1 diabetic. She was 24, 25, something to that effect. She was she was a relative of somebody who was a healthcare administrator who knew me. And I received a text from the relative saying, "Hey, she's a bad diabetic. She can't see out of one of her eyes. I'm very concerned. I want you to see her." I said, "Absolutely." And she shows up to me, and she had a terrible complication from diabetes in her one eye that required immediate surgery. And the outcome was very iffy. And the other eye, which she saw perfect out of, was on the verge, not to her knowledge, but when I did testing, was on the verge of the same kind of outcome.
yeah, it's an vascular
And
collapse.
so we start medical therapy in the good eye, and I take her to surgery, in her bad eye. In the meantime, she gets pregnant, and now she's dealing with recovering from a multi-stage surgery in one eye, and the other eye is doing well. And as the pregnancy goes on, and sometimes what happens for pregnant women who have diabetes, the diabetes escalates,
Yep.
and her good eye filled with blood. And so she had a situation where she's recovering and wasn't seeing very well for the time being out of her one eye, and her good eye, now she can't see anything out of it. And couldn't clear it with medical therapy, and so she needed to go for surgery. And so there she is. She's 38 weeks pregnant. She's functionally blind. And right before I took her back for surgery to try and fix her, quote unquote, good eye, she's bawling her eyes out, and she says to me, I mean, this is literally 5 minutes before we go back to the operating room. She says, "I'm never going to see my daughter's face," right? Because this is her first child. And I thought to myself, okay, Matt, it was a Thursday morning. I was like, no pressure, right?
Yeah.
And unfortunately, through lots of mechanisms, right, she ends up doing just fine. She sees perfect out of both eyes. Both eyes recovered very well.
Nice.
She has two kids now. I actually just saw her kind of recently, because now I don't see her with much frequency. But I mean, it really does magnify like the intensity of what our vision can be, the life-changing situations. It easily could have gone the other way for her. And that changes everything. She was, working and looking forward to a life, and that could have easily all been taken away, and she could have been blinded and, disabled and never seeing her two children's faces. And now she's happy as a clam, and, and I'm grateful, for the outcome. But yeah, it's intense. It's meaningful.
Oh, for sure. That's a great story. Thank you for sharing. I'm glad it had a happy ending.
Me too. I always tell her I think I lost 5 years of my life doing that one surgery, but that's okay. I'm a youthful guy.
Yes, yes. All right. So, do you have any big 2026 plans for the group or personally?
I mean, our group just keeps growing. We continue to add doctors. We just opened a new brick and mortar office of our own down in Casa Grande, which we're excited about. We're on the cusp of opening a brand new office in Mesa, which is an area that we've serviced, but we've been in need of having just a larger facility to be able to handle the patient care. So lots of good things happening in my practice. Personally, right? Like, I don't know. I'm in a good spot. I love what I do. I've got three healthy, beautiful kids. No complaints.
Excellent. All right. Well, Matt, if people would like to connect with you and learn more about what you do, where can they go? What should they do?
Easiest thing is, through the web, associateretinaconsultants.com. That basically gets you plugged in to everything and anything you might want to know about our group, me, what we're doing professionally.
All right. Well, thank you, Dr. Welch. We very much appreciate you being here today and sharing your insights into sight. That's awesome.
Oh, it's been my pleasure. It's been great.
Thank you.
Inspired by our guests? Visit phoenixprosperitypodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.